Hello and welcome to DAS Health's webinar, Stop the Manual Madness, Maximizing Aprima for MIPS. My name is Bridget Peterson and I am part of the Government Incentives team for DAS Health. Before I get started, I would like to take a moment to explain the process for today's presentation. First, I would like to mention that this webinar will be recorded and we'll send out a copy of the slides and recordings within the next week. Next, for those of you who aren't familiar with DAS Health, I encourage you to visit our website, connect with us on LinkedIn, and follow us on YouTube, where you can access all of our historical webinars. I also want to mention upcoming educational webinars we'll be presenting in March and April. The first is Lessons Learned from the Pros, MIPS Submissions Do's and Don'ts on Wednesday, March 15th. Achieving NCQA PCMH recognition utilizing Aprima EHR, which will be on Wednesday, March 28th, and MIPS Math 101, the ultimate guide to MIPS scoring, on Wednesday, April 19th. We will be sending out an invitation to these a week or so before each date, and we always post on our LinkedIn page as a reminder. So keep your eyes peeled for that. Okay, so back to today's webinar on Stop the Manual Madness, Maximizing Aprima for MIPS. At the end of our presentation, we will open up the floor for questions from you. We will answer all questions at the end, but you may type them in the questions area of the webinar control panel whenever they occur to you. Finally, for audio clarity purposes, everyone's phone will remain muted throughout the entire webinar. If you are experiencing audio issues, please use the chat box to let us know so we can resolve them. And again, questions may be entered in the question box. So without further delay, I would like to introduce you to the rest of our team who will be our presenters for today. We have Lindsay Lanning, our Government Incentives Manager, and Kimmy Watson, our Government Incentives Assistant Manager and our resident Aprima expert. So Kimmy, the webinar is all yours and feel free to get started when you're ready.
Thank you so much, Bridget. Hi, everyone, and welcome to today's webinar. We have a lot of fantastic information for you today. So without further ado, let's get started with Stop the Manual Madness, Maximizing Aprima for MIPS. Our plan today is to start with a review of the MIPS basics. This will consist of some basic information for the MIPS program, as well as what reporting will look like within Aprima. We'll take some time reviewing quality workflows that can be automated and the process to automate them. We will even take a look at some of the most common quality workflows within Aprima. Our hope for those of you who are not so familiar with the ins and outs of reporting within Aprima is you will come away with feeling like you have a better understanding of how you can truly make Aprima work for you with MIPS. Once we make it through the quality workflows, we'll review the sending and receiving health information workflows for your direct secure messages and how to configure patient portals for the provider to patient exchange measure in your promoting interoperability workflow. After we have well and truly overwhelmed you with steps and workflows within Aprima, we'll show you how we at DAS can help you be even more successful in the MIPS program and earn that positive payment adjustment. To get us started, I'm going to hand it over to Lindsay to kick us off with the report basics. Lindsay?
Awesome. Thank you so much, Kimmy. Well, as promised, I am here today to cover the basics. Now, I assume most of you on the call either are familiar with MIPS or at least have heard of it before, right? Why else would you join? Just curious. So we have plenty of other webinars that break down the program and its requirements, if you are new here today. So those webinars are going to go over those requirements in much more detail than we are today. We're just going to give you a quick overview so we're on the same page. So MIPS stands for the Merit-Based Incentive Payment System. It is a CMS-ran program, and it's going to require clinicians who treat Medicare patients to report data on the quality of care they're providing. Then you can in turn earn a performance-based adjustment based on that data, which can either be bad, aka a penalty, not something anyone likes, or good, aka bonus or incentive payment, which is absolutely the goal and the perk of participating in this program. Your performance is actually measured across 4 different areas or categories, as CMS calls them. So that's going to be quality, improvement activities, promoting interoperability, and then cost. All of which are going to be over a full calendar year. There are some differences between each categories that we'll look at today. And on kind of that screenshot on the screen, you can see some blurbs about what each category entails. But these categories are what control your score. Each one has different requirements and their own scoring complexities, which again, we aren't going to focus on too deeply today. We're going to give you a brief recap to kind of jog your memory on each category. But as Kimmy said, our primary focus today is how to use Aprima EHR to meet all of these different required measures to make your lives easier. That's our goal. So if we start with quality, again, tip of the iceberg overview here. The quality category is reported on for a full calendar year, meaning January 1st to December 31st. We are tracking that data for a score for a performance-based adjustment. This category is going to be worth 30% of your total final score. And there are a total of 200 plus measures to pick from across all the different submission types. And you only actually have to report on 6 to be scored on. One of those 6 does need to be an outcome or a high priority measure if an outcome is not available. And then last but certainly not least, scoring. So scoring for these measures in this category depends on benchmarks, and those benchmarks are published by CMS. So let's dig a little bit deeper into this before we jump into Aprima. Scoring is based on benchmarks released by CMS each year. What does that even mean, Lindsay? Well, I can tell you one thing. Gone are the days where, for any of these categories, if you hit a certain percentage, you pass a measure. Those are the old legacy, meaningful use or PQRS programs. Now, you need to score as high as possible on every measure, and how many points you get for each one of those measures in the quality category specifically will depend on the measure's benchmark. So I think we're familiar with the basic concept of benchmarking, right? Overall just comparison. But in this scenario, you'll look at your performance rate, that percentage that shows on your quality report, and compare it to the benchmark CMS created for that measure. And it will tell you exactly how many points you earn out of 10 based on what decile it falls into. So you can see on the screen, I pulled a portion of these benchmarks from the CMS file. Why this gets so tricky is because you can see, for instance, what I've kind of boxed out on the screen here. Documentation of current meds. If you earned 90%, you would only earn 4 out of 10 points. But for depression screening and follow-up, that measure, for that same 90%, you would earn the full 10 points. This complicates things massively. And get this, they release benchmarks every single year. So all of these ranges change year to year. So you can see why it's so difficult to understand your own data, because you can't just look at your report and pick the top 6 measures with the highest percentages. It's now all about the benchmarks. And don't even get me started on if there isn't a benchmark for a measure or if there's a 7-point cap. But really, I won't even get started on those. We're going to be here all day otherwise. Again, we have plenty of historical webinars that go over that. Now, if you're already working with our team on MIPS, I do see some friendly faces, or I guess I should say names, out in the audience today. You can disregard this. We don't want to overwhelm you. We export your custom monthly reports that take care of this entire scoring process. That's what we are doing on the back end for you. And yes, that was a shameless plug to work with our team, but this stuff is not easy, guys. It's our full-time job, and against unpopular opinion, we do love it. Okay, so moving into Aprima, you've got your groundwork here. The first step to understanding your quality score is to run your report. You need to see your performance rates to be able to compare those to those benchmarks we just went over. So let's walk you through running your report step by step. This screen should look familiar to everyone, or I hope. So from your Aprima dashboard, you can access the report functionality by selecting that icon that I, again, circled or boxed on the screen that you're seeing. Now, if you do try and click this icon and you don't have the correct security set up on your specific user account, you're going to see an alert pop up from the system stating you don't have the correct securities to access this. I'll be honest, we don't come across this too often. Most of user profiles and securities that are automatically set up or defaulted should be able to access this report's functionality. However, we have found, and we've seen it, for example, if you only have registration access, that specific user profile is not going to allow you to access the reports function. So just keep in mind to make sure everything's set up correctly on the back end if you do receive an error once you click that icon. Again, once you click that icon and you have those correct access privileges, the view report window will open. So this is where essentially all Aprima reports run out of. It is the reporting motherland in your system. Now, for MIPS reporting specifically, you're going to have to navigate to the file folder icon marked clinical quality and expand it. And from here, you'll then want to select clinical quality measures. And this is where you select your report parameters to run your report. So you're going to have to enter the following fields. We've identified or boxed out again here. Those include, the CQM reporting year. So you're actually going to want to put CQM 2022. Now, I know we're in 2023, Lindsay, sounds a bit fishy, but until Aprima releases the CQM 2023 program later in the year, this is what you want to use right now. Next is the CMS program. So for traditional MIPS reporting, which we're talking about today, you would select either individual or group reporting, depending on how your practice has decided to report. Then provider, and then measured date. You actually want to type out current year for that measured date. And then the best part, the measure name. Here is where you input which measure or measures to add to the report. Now, please note, the more measures you run at once, the longer the report will take to generate. So when your parameters, are all set, you've got everything finalized in here, you can actually click that view button to go ahead and generate your report. Now, your first pro tip from the experts here is once you have those measures, added that you want to report on, you've got all the criteria entered, before you hit that view button, click Save As in the top right, and this is going to allow you to run future reports with the exact same parameters. So once you hit Save As, you would then enter in the name of the report. So you could put something like MIPS group quality report or MIPS individual, insert, provider name report. And that would actually save that as a memorized report to save you some time in the future. Another cool feature that's, relatively newer in the past few, year or two, is that you can also schedule the report to run at a later date or at a future date here as well, which you can see in that second screenshot. Unfortunately, this typically isn't instant. Your reports are actually going to take some time to generate. How long, again, is going to depend on the number of measures and the time period you selected. It's a big difference from running one measure for a quarter versus, 12 measures for a full year. While your report is generating, what you see right here on your screen will show on your screen. If you close out of the report, your generating report screen window will also close, which is okay. We just wanted to warn you that that would happen. It will still run. And please note, because we do get this a lot, that duration listed here on that screenshot is actually the time it takes for the report to run. It'll actually continue to count forward as your report prepares to generate. It's not actually a countdown to when it's ready or how long it's going to take. So what next? When can I see my data, Lindsay? Well, once your reports have successfully ran, you're going to go ahead and navigate to Document Batch Management. So to do so, you're going to go to Tools, again on your dashboard, and then to Document Batch Management here, a little more than halfway down on the options. And DBM, what we have lovingly termed Document Batch Management on our team, is where basically every generated quality report lives and where you can access your data. So once Document Batch Management opens, you're going to want to enter a created date here. The created date range will be when the report was ran, not the visit dates associated with it or the time frame you ran it for. You're not trying to put in last year. Again, you're just trying to put in that created date of when the report actually ran. So a good rule of thumb, or what our team typically does, is we actually type out last 10 days or last 30 days. Just don't get confused with what that's asking for. And then you would just go ahead and select search. And then you'll get results back showing all the reports you ran in the last 10 days, if that's what you selected, in a grid format or a table. To actually open your newly generated quality report, you would just select the report with the correct name, and that name is going to show in the description column for you. So it should be pretty clear which one to select. So at this point, you ran your report, it's generated, and you can now view your data. Exciting stuff, right? You'll notice over the past few slides, we were very descriptive. We will continue to be throughout the webinar on purpose, as we are going to send these slides out so you can use this as a guide on where exactly to click or what exactly to fill in, because again, that's our goal, to make reporting easier for you within Aprima. So it wasn't a mistake. Lots of words and lots of images on the slides today, just because we do want this to be a tool and a resource for you. Okay, now you have your report. You might be thinking, woohoo, I did it. Now, what do all these numbers mean, and why is everything yellow? I can't answer the yellow question, but I can tell you what we are looking at. So let's break this down. The top portion of the report is almost like an overview or a summary table, right? And then you can go ahead and scroll down with your reports live, and you can see much more detail on each measure individually. So on the first column here at the top is your measure ID. This will tell you the ECQM number associated with the measure you're tracking. For example, CMS 68. That's documentation of current medications. CMS 69, that's BMI tracking and screening and follow-up. CMS 50, that's closing the loop on referrals. Believe me, I can keep going. It's one of my very few party tricks that I have. Now, we obviously have these memorized, but the good news for all of you who don't, right, is that the measure title is going to be displayed down below in that e-measure title section, so you won't have to guess. You'll just have to scroll down for the report to understand which measure is which. The next column is your numerator denominator data, showing you how many patients counted towards or were included in each measure, aka the denominator. Pro tip, you want your denominator above 20 by year end in order to report on it. And then the numerator, that's your number of patients or visits that met the measure out of all of those that were included in it over the year. Again, I won't lie to you. I know we're building some trust here today. So please note, not all zeros in the numerator are actually bad. Keep an eye out. CMS does have what are called inverse measures, where a zero or a lower percentage is actually good. Take, for example, CMS 156, use of high-risk meds in the elderly. I know I'm showing off again, but if you think about it, you don't want to prescribe high-risk medications to elderly patients. So a zero is good. It's actually great. It's a perfect score. Then you have your performance rate. This is a flashback to your fractions lessons in grade school. It is the numerator divided by the denominator. And this, my friend, is the percentage or the performance rate you compare to the benchmark table I mentioned earlier. So this is key. Speaking of deciles here, you do see a decile column here at the end, which should theoretically help you score your measures using that benchmark table. However, as you can see in this example, it does often pull in some question marks, leaving that scoring up to you. And last but not least, you can see further down the report, outside of that summary or overview section is that measure breakdown I kept referring to. So, we are looking at the first measure, CMS 68, in greater detail here. What I want to call out, do you see where that denominator number of 85 is underlined? Remember that. Because in order to use this report to actually interact with your data, manipulate the data and affect change here, you're going to need to click on that underlined denominator number. Our best practice, or how we use these reports and how we encourage our clients to use these reports, is to select that underlying denominator value and review patients not meeting the measure. So once you select that underlying denominator value, you're going to see this aggregate patient list detail and a table with all the patients listed. We want to focus on the numerator column, specifically patients with the status of no. The ones with the status of yes are meeting the measure, meaning they're good to go, they're counting in your favor, you did what you needed to do. You can then hit the no that shows on a patient to be taken to their review past notes to review failing encounters. Maybe you got the patient's, height and weight, so their BMI calculated, but you forgot to add the education if they were out of a normal range to get the credit. So you could go back and do that, and then they would count for you the next time you ran your report. Now, if you, ever want to compare a visit that maybe met a measure, so you could always click that yes and see what was documented to get you credit. So again, I will say we do sometimes use that yes functionality or those yes patients as well, just to learn from a documentation standpoint. You can compare your yeses or nos and see what's missing. So at this time, you now know how to generate your practice reports, access where the reports live once they've generated, and how to decipher the numbers that are actually being generated. And yes, that was surprisingly just the basics. So in our next section, we're going to review some of the most popular quality measures and how you can automate meeting them within Aprima to save you and your staff a lot of clicks on a daily basis. I'm actually going to go ahead and turn it back over to Kimmy, who's our expert on this. So Kimmy, it's all yours.
Awesome. Thank you, Lindsay. Okay. So let's start with meeting the most basic quality measure available to us, right? Documentation of current medications. Sadly, I have no automation to share with you on this one, but I can tell you how to meet it with just one click. So most commonly, the simplest workflows are often the ones that are overlooked, right? So documentation of medications is no different. In any patient's note, you'll want to access the patient history tab and select the checkbox for the medication history line item. You'll notice on the picture on the left, right at the bottom, when the box is unselected, the note states, I have not reviewed the medication history with the patient, versus on the right, when it is selected, it will change to, I have reviewed the medication history with the patient. This will need to be completed on each patient's note. And historically, this is able to be updated at any point in the measurement period for you to get credit. So if you forget to document this on a patient, you can review your report and evaluate the patients in your denominator, come back into their note and update it. So once you locate that patient's most recent note and update it, and ideally this workflow should be done in real time, but as specifications continue to update from year to year, the timely documentation of this could affect your performance. So make sure you're documenting as close to real time as possible. Timely documentation is essential for vital-oriented measures like CMS 22, which is preventative care for high blood pressure, the CMS 69, which is your BMI screening measure, and even CMS 165, which is your controlling high blood pressure measure, and many others. So in other words, vitals are vital to obtaining credit for these measures. Many practices are configured with custom vitals to suit their everyday needs. And if your current vital configuration is lacking some necessary fields, we're happy to work with you to make those customizations as part of the support we offer our clients. Gathering height and weight and blood pressure are the most popular components you could obtain to gain credit for these measures. So shameless plug, if you need help, feel free to reach out to us. So if for whatever reason you're unable to capture vitals for that patient in real time, the next visit for that patient will need to contain the vitals if possible. You can always utilize the patient refusal checkbox for any patient you have who's not been able to receive vitals on. And the good thing is for height, weight, and blood pressure fields, the follow-up will trigger automatically based on the code that drops to your services provided tab in the note, which brings us to our next section. Follow-up measures, what are they? So these are measures that require some sort of follow-up education. In our case, in the place of an education form. If your patient is outside of normal parameters, or even if you just want to include general education to your patients for their health and wellness, we can set up these by accessing List Editor and the clinical functionality. You'll notice there are two options for education forms. One is the education form, and the other is the education form association. So you may be asking, what's the difference? Am I right? I'm not a psychic. I'm here to keep you informed. The difference is that the education form shows you all the available forms. So think of it as List Editor is the library and the education form section is the book. Still following? If that's confusing, no worries. Just know that all the customizations you'll be doing will be in the education form association. That's where all your configurations and your customizations live. So just to reiterate, education forms are just the are just the form's education form association is where all the customizations live. So you may be wondering now, well, Kimmy, how do I set those up? Surprise, I read your mind, 2 for 2, right? So let's get into it. For example, we'll set up CMS 139. That's screening for future fall risks. From the beginning, we have opened List Editor, right? You've opened up the clinical category, you've opened up the education form association. Select the education form association your providers are currently configured with, and once that's open, you'll see the screen pictured on the left. Locate a blank square and select the option to open the patient education form. This will be the education form that will link to the note. And once you select that magnifying glass, we'll be able to search for the education form we would like to trigger in the patient's note. So we are now in the Find Education Form screen, and from here, we'll search for falls and modify that desired education form. And when we modify the desired form, we'll be able to link a procedure, which will look like this. So we link the procedure that will populate in the SP tab. In this case, it's that 3288F CPT code, and this will be the procedure linked to this education for now. You'll notice the View Content button located just below that, and that will allow you to preview the patient education that will be provided to the patient upon checkout. As noted in this slide, any custom procedure can be linked to this patient education. So you've now entered the procedure that will pull to the SP tab, but what will cause the code to trigger? We need to enter the patient's demographics, and that should receive this procedure code. Okay, lots of information here. So now we're setting up the demographics, right? So by entering the age range that the measure will apply to, as well as how often you would like the education form to trigger for your patients. So for CMS 139, we'll enter the age range for patients over the age of 65 to 100, and that it should recur every year. You'll notice the other factors on the right-hand side of these, and these other factors are used for your BMI and tobacco cessation measures. And lastly, we set up the procedure codes that will trigger this 3288F code to pull into the note. So for the screening for future fall risk, we want to use E&M codes your practice typically uses for the new or existing patients, because we want this to trigger on every patient who meets the demographics for this measure. Now, the one caveat is that it will trigger on every patient's note that is in the demographics. You only need one visit to get credit for this measure, so we can either leave the code for your patient's second visit or subsequent visits to your practice, or we can remove it. Either way, the following year, you will want to make sure the patient has the code triggered on their note. Removing the code from the subsequent visit will not prevent you from getting credit for this measure. So once you've entered the desired 9920 or 9921 codes your practice uses for your new or existing patients, you can save out of the education form association, and we can test your new education form on a test patient to be sure that it triggers properly. So you've made it through the steps for creating and customizing an education form. Congratulations! Let's test it by opening a test patient's note. Chart an E&M code that you entered in the previous step, for instance, this 99212 code, and you should notice that the CMS 139 will automatically update into your patient's note. As a quick aside, you'll want to make sure the test patient you're using meets the demographics and is over the age of 65. Your new CMS code will populate in the note. If your test patient isn't going to be in that age range, you'll notice nothing populates. So just go back and check and make sure that that's in the proper age range. Review your education form slider, and you'll see the falls education form is now triggering in the slider. And we did it! The good thing about this feature is it's highly customizable, and we could use it with any number of combinations of procedure codes. Automation within Aprima can make documentation more cohesive and even more efficient. So, education forms are here to make your documentation of clinical quality measures easier. And we can set up a number of these measures for you when you sign up for our MIPS assistance. So we have now reviewed how to generate the reports, how to access your data, how to automate documentation by using education forms, and next we'll review some additional customizations needed for some of those popular clinical quality measures. Okay, so cancer screening measures can be documented in the patient's note in either the history tab or the SP tab of the note. They can also be documented outside of the patient's note in their history or in the SP tab. And if documenting in the history is what you're wanting to do, a number of customizations are necessary to ensure the Aprima system properly counts the patient in the numerator. In this section, we'll review those configurations and customizations together so your patients who have been screened for any of these measures will properly count in your reports. Just to note that SNOMED codes are often used in these customizations, and for these measures, they are absolutely necessary for proper documentation. Let's get started in reviewing how to set up your cancer screening measures for proper documentation. Okay, so in setting up your procedure term, you'll want to access List Editor again, surprise, surprise, and under your KDB settings. This is where all the dynamic functions for your documentation live. So right now we are concerned with the procedure history term function, and this is where we will be creating those custom procedure panels that will allow us to document our patients' cancer screening measures. We want to create a brand new procedure term for, let's say, a colonoscopy measure, and you'll give your new procedure term a name, and you'll enter in CPT codes that your practice is using, and you can even enter multiple if desired. So your practice uses any number of custom procedure codes for colonoscopy, that's where you'll enter this field. So you can enter your custom code or even include the one that's in our DAS Health Aprima ECQM manual. And you'll want to enter a history group as well. So your history group we primarily use is the preventative care, and it will be consistent for any cancer screening measure. And we'll add in a SNOMED code indicator and or a LOINC code where needed. And that's it. That's not too bad, right? Okay, so now we've entered your procedure term, and when documenting in the patient's history, and we're back in that patient's history tab, you'll notice that there are two boxes on the right-hand side, and one will be the procedure term, and the other will be the procedure. If you use the procedure one, this will only bring over the CPT code of that procedure. So if you have a custom code that's a CPT, that will only bring in the procedure, not the customizations you just spent all that time building. No, you want to get credit, right? So let's use that beautiful procedure term we just spent all that time building out. Once you select the magnifying glass for the procedure term, you'll notice that it's blank. If you haven't used this feature before, and if you have, there will be previously selected terms in there, so go you, ahead of the curve. But regardless, since we set up a brand new term, go ahead and hit that handy search button, and you'll notice your new procedure term there waiting for you to select. Once selected, be sure to enter the resulted status and the date and be sure to save, and that's it. Phew. So I know we reviewed a lot of steps and I hope that wasn't too confusing, but let's find out for sure. Bridget?
Wow, that is a ton of great info, Kimmy. And yeah, you are making my head spin. So let's check in with our attendees and make sure they are following. Going back to the very beginning, if we were to look for a generated report we just ran within Aprima, where would we find it? Would it be A, list editor, B, the help section, C, document batch management, or D, generate documents? So we are going to launch this poll and give you all a minute or so to answer. And we aren't heartless. We didn't ask you the steps to configure an education form. We just wanted a quick pulse check to make sure everyone is still with us. So give you guys a couple minutes, or 1 minute really.
It looks like responses are still pouring in, Bridget, so we'll give everyone here just a few more seconds. It looks like we're slowing down a little bit, so I think we're going to go ahead and close it in 3, 2, 1. And we'll go ahead and share the results.
And the results are in. Yay! We found that the correct answer was document batch management. Great job.
Awesome, everyone. Okay. Well, based on those results, I think we were at 75% document match management and 25% on that generate documents, which was an absolute made-up term, I believe, that Kimmy created just to try and catch people and slip you up. So don't feel bad. We've got a ton of quick learners on our hands in our group today. So nice job, everyone. I do hope you all are still with us. I know we've discussed at length the components that contribute to quality, right? Workflows, reports, and now even customizations and automation. I'm going to go ahead and jump in and take you through the PI, or promoting interoperability category. Same idea here. What is PI? How do I run the report? And then Kimmy will take you through the need to know workflows for PI. This section will be a little bit shorter, but fun fact for this category, you don't have any choices. You can't pick which measures you want to report on. Everyone reports on the same measures nationwide, which is great for us today because we can actually take you through the workflows that all of you will have to, participate in order to report under the PI category in MIPS. So the PI category is reported on for a minimum of 90 consecutive days during the calendar year. One thing to note, not the full year. Quality is a full year, PI is only 90 days. Another thing to note here, it doesn't have to align with a quarter. You could start on any date you want. You could start on April 8th if you wanted to. I don't know where that date came from, but it did. But note, all measures in this category have to have the same 90 days. This 90 days, the PI 90 days, and for the improvement activity category, which we're not going to talk about today, is also 90 days. Those 90 days don't have to match up, but all of your measures in the same category do have to have that same reporting period. So, for example, right, you can't report on one measure in Q1 and, e-prescribing in Q1 and then your patient portal access from August to October, if that makes sense. Now, this category is worth 25% of your MIPS final score. Keep in mind, quality was 30%. And I already mentioned these measures are the same for everyone, but there are two types. So attestation measures and then measures with data. So attestation measures, you're just saying, yes, I did this. There's no associated with, no data associated with these. And these are things like security risk analysis. We have the new, I guess, technically last year, but really required for this year, the high priority practices SAFER guide that needs to be completed. You have the electronic case reporting and immunization, registry that has to be completed if you treat patients or provide those. And then, now again, newly finalized this year as required and no longer a bonus is the prescription drug monitoring program. Those don't necessarily have data associated with them. I'm not going to say that they can't, but they're much more to CMS's eyes saying, yes, we've completed these. But you also have measures that do have data. That's going to be your e-prescribing, right? This has been around since meaningful use days. It's pretty much second nature to everyone. You have your HIE send and receive. These are going to be sending and receiving, referrals or CCDAs electronically using those direct addresses. And then you have your patient access measure, or providing your patients access to a patient portal and uploading data to that in a timely manner. And then last but not least, scoring for these measures. Specifically in the PI category, it's actually a bit more straightforward. You don't have to compare it to a benchmark table, but it's still not super clean cut, basically. So each measure has a different weight associated with it. For example, e-prescribing, it's only worth 10 points, whereas the patient access measure is actually worth 25 points. So an 80% performance rate on e-prescribing is 8 points, but on patient access, it's worth 20 points. So again, grade school math lesson here, convert the percentage to a decimal and multiply by the measure weight. But I digress, I'm sorry. I can't help it. I swear I get MIPS word vomit when I present because I get excited and I want everyone to understand it the way we do. But again, now that we have that kind of 30,000 foot view of PI and what's required, let's look at how to access your data in Aprima for those measures that do have data that you want to track. So, look familiar, anyone, where we're at? You're going to gain access to your PI reports from that same icon on your Aprima dashboard, and then you're going to navigate to that clinical quality folder and expand it. Only this time, you're going to select the 2022 Promoting Interoperability option. Again, 2023 PI program will be released by Aprima later in the year, and we definitely recommend that you run that one once it is released. But for now, we're going to focus on 2022. Again, you're going to input the parameters for the report. There are a few less this time. We actually just need the providers and visit dates, and you're going to want to put current year for that visit date. And then again, everyone has the same measures, so there's no need to pick any this time around or add any. The report's already going to know. And don't forget, you can save as to memorize this report as well for PI for later use if you want to. But again, from here you would hit view. Your report will generate. It may take a few, same idea with quality that we already went through. I will say the PI ones tend to take a bit less time, but again, you would go back into document batch management, you would find it, and you would open it. So you'll see once you open that what is showing on the screen here. No yellow, but a bit more words explaining each measure. So this report is basically, it follows the same concept as our quality ones. It's interactable. So you can review your patient populations for a particular measure by selecting, again, that numerator or denominator data using that same process that we went through of clicking and reviewing patients who had a status of no and going back and working those visits to improve your performance. Now, something I want to point out that is key. Any work on these visits must be completed in your 90-day reporting period. If you're audited, and let's say your HIE send, or technically on the report, it's called support electronic referral loop by sending health information measure, long name, you can see why I call it HIE send, is a 5 out of 5. CMS does not want to see that 3 of your 5 visits for that measure specifically had a direct secure message sent in October when your 90-day reporting period was January through March. I didn't call this out, obviously, in quality because the reporting is a full year. So, obviously, if you're making changes and improving your score, that's just going to happen typically naturally. And don't worry, each one of these measures, we are going to touch on the workflow for each of these in a bit. Like I said, Kimmy will dive into that. But, this is the report. It's the same process to run and really interact with your data as your quality report. So we're old pros at this point. Now, again, since these measures are the same for everyone, Kimmy's going to walk you through the steps on how to meet them. In particular, I think we've got e-prescribing down, right? Patient portal is pretty easy, and Kimmy can attest to that. But really focusing on the 2 HIE or DSM measures here will be huge. So, Kimmy, take it away. I'll stop talking.
Thanks, Lindsay. We're going to review the workflows, as Lindsay said. And if you have any questions about a direct message, we can review those as they come in. Sending is just an easier process to review, less patient at risk. And I'm looking at you, HIPAA. But okay, let's get into it. Okay, so you want to send a DSM, right? So first things first, you're going to determine who in your practice will be sending the notes and whether it will be the provider or staff. And there are 2 ways you can send out referrals in Aprima to get credit for MIPS. And it's a 2-part process, right? So why I say determine who will be sending them is because the provider can order the referral in the note on the SO tab. But for the sake of time, I'm going to show you the workflow that can be done by anyone in the practice. Front desk staff, back office staff, the providers, anyone. This is for ease of use and for getting credit. So part 1 is setting up the patient-provider relationship. And how we do this is by using the patient-provider tracking. So patient-provider tracking is located in any patient's demographics. It's that icon right at the top. It's like the human icon with the comb. And this step is consistent with both sending and receiving. So you will always start here for referrals. And once in the patient-provider tracking, you'll want to select New to create your new patient-provider relationship. So once you've selected the New button, you'll see this new patient provider tracking screen come up. And there are 4 fields you'll want to make note of. These are the provider, the provider's role, the role active date, and the referral, and the add referral button. The provider will be the provider you're referring to. And for all sent referrals, this role will be specialist, unless you know the provider who you are attempting to refer to does not have a DSM address. So that's a very important aside. If you're referring to a provider who does not have a DSM address and you know that they don't, their role should be other. So the role active date is not required, so that's why it's not selected here, but I typically encourage you to put the date for when you're attempting to refer the client, as it will help for future reference when the referral is set up. I've seen a lot of practices who haven't used this field and have been wondering, well, why is this patient not been referred, or when did I even start this process, because of how long it takes that patient to build an appointment and all things that happened on the back end. So role active date is not required. And lastly will be the add referral button. This will be where you will link all visit and appointment and associated information. So when you select the add referral, you'll notice that the new patient referral window will appear. The status for all sent referrals will be initiated, and you can enter when the appointment will be booked. And typically we leave that as is unless the patient already has an appointment booked or you plan to schedule it right then and there. And finally, the requesting provider will be your internal provider who has seen or plans to see this patient. So a quick note here, once you have sent out the referral, which we will review as part 2 to this process next, once you've sent out the referral in the new patient referral screen, in that related visit, that will need to be entered, and the status would need to be changed to completed. Most commonly, when clients report having run their PI report and not received credit, this status not changing to completed is the culprit for your DSM not calculating to your report. So you'll want to make sure that this is always updated once you have sent your referral. Okay, still with me? Let's get to part 2. Okay, so part 2. Okay, so let's send it, right? We will access generate documents and enter the desired visit. So we'll link the related patient referral, which is just a fancy way of saying link that patient relationship you just created, and select the formatting model you would like to send, which will always be the CCDA. You may add additional formatting models if you would like, but the CCDA is what is mandatory in getting your credit for the DSM message. And once you've selected the formatting model, hit print and we'll be one step closer to done. Finally, and we're almost done, I promise. Part 2 can be the easier step if the provider you're planning to send to is already set up as an external provider in your practice. If not, no fear. You see that lovely little magnifying glass in the provider line item? You can always review the provider you selected and modify their configuration to review the direct message tab to see if there is one linked to their Aprima profile in your database. Even better, you can search for a provider as well. How nice, right? So if the provider you selected does not have a DSM address configured to their profile, you'll know. And how will you know, you ask? Well, you see that message section with the subject and message text boxes? Those won't be available. The screen will default like you want to print the report rather than send electronically. Luckily, our example does have the option, and we can enter the subject as referral and message as, please schedule patient. Of course, you can customize that however you want to include with more or less information, but it's not required. You can put in just referral, please schedule patient. Keep it simple. Finally, you'll want to make sure there are DSM addresses in the direct and to and from fields. And then once you've got those 2 addresses in there, you can hit direct and you're all done. But you may be asking, Kimmy, how do I know they sent correctly? How do I know they actually left the system? Well, gotcha, 3 for 3. Wow, I'm on a roll. All right, so you'll check that your DSM sent correctly. You'll want to go back to your main Aprima dashboard screen and select under desktop and select the interface data detail. The interface data center will open, and that looks like this on the right-hand side of the screen. And it's just all of the background jobs that run in your practice database. But we are only concerned with the message type. So in that message type, you'll select the magnifying glass, hit search, and look for that SureScript direct message. That is the only message type that we'll be using. And then you'll want to select the time period of when you sent the DSM. I like to check these in real time since the resource is not patient specific for DSM messages. It's time-stamped, but not patient linked. So you'll want to be aware of the time range that you sent the DSMs. If you happen to only check this at the end of the day, you'll want to just take a note of, oh, I sent these DSMs around noon today. That way you'll be able to reference it back in the interface data center. So You send the DSM taking note of the time that you sent it, wait a few minutes and run your PI report, and oh no, it's 0/0. So you come into the interface data detail and make sure that there are no errors present. If it says there's an error, you'll retry to send the DSM one more time and then recheck the IDD and see if it says successful. If it says successful, rerun your PI report and it should reflect 1/1. But if it does give you an error, reach out to our support and we'll be able to review for escalation if needed. And that's it. You've successfully sent a DSM for your promoting interoperability. We have one last workflow to review, and this one is even simpler. Can you imagine? So the final measure that we'll review for today is perhaps the simplest, provider to patient exchange. This looks at your patient portals very simply. You'll need to access your PI report and navigate to the provider to patient exchange measure. And you'll notice in the report that there is a blue colored numerator and denominator, like Lindsay said before, and you can click the numerator and denominator, which will generate a list of patients currently calculating for this measure. At the top of your screen, you'll notice the blue page arrows. I always recommend going to the last page of this report, and you can do this by hovering over those icons, looking for the one that will say, go to last page. Locate those patients measuring 0/1, and those patients' names will be in blue. And from this report, we can actually make adjustments. So if you have a patient who's measuring 0/1, select their name, and that will open up the demographics. Once you're in the demographics screen, like pictured, you'll navigate to the questionnaire tab here and select create web account and OK to save their new credentials. That's it. You've created their web account. That's all. You can rerun the report now. So hopefully not too difficult, but I do know we reviewed a whole lot of workflows today. So to make sure you're understanding, Bridget has another question for you.
Yes, I am back. Okay, again, with just a quick check your understanding for the PI side of the house. We will go ahead and launch another poll where you can answer. When sending out a referral for your patient from provider patient tracking, what is the provider's role if you are setting up a new provider? Will it be A, clinician, B, referring provider, C, specialist, or D, I'm going to be honest, I am lost. And that is okay. We are here to help you. And if you need additional guidance, do not be afraid to use the chat or reach out to us after. We will share our contact information at the end of the presentation, which we are getting very close to.
Awesome. I still see some responses rolling in here, so we'll give everyone a minute or two.
Awesome.
I'm excited. I can see the background here. We got a little bit of a mixed bag over here. All right, I'm going to go ahead and close the poll and share the results in 3, 2, 1. Awesome. Well, I'm going to go ahead and share these for everyone to see. Kimmy, I think we're going to have to go through it again one day. You know, it's a lot. It's a lot of steps. So we've got kind of a mixed bag here between referring provider and specialist. And whoever, the 20% that said, I'm going to be honest, I'm lost. I hear you, and I am here for you. Let us know if we can help. Absolutely. But Kimmy, do you want to tell us the correct answer? You've got to split.
The correct answer is specialist.
Woohoo! So a little bit of a mixed bag here, everyone, but thanks for participating. Just keep in mind, obviously, when you're in those steps to pick specialist, even though our referring provider does seem like it'd be the most kind of logical answer, but that's why we're here. We're here to give you the pro tips and teach you, what we're doing and how to make your life easier and meet these measures. Okay, so again, to be fair, that was a hard one. So to wrap things up today, I do want to remind everyone of a crucial requirement under the PI category that we didn't really talk about today, and that's that you have to be on a certain version of your EHR to report. You have to be on what CMS calls certified EHR technology, or CERT, and it has to be 2015 Cures compliant. And that's new this year for 2023. I don't know if you remember, I'm trying to think of when the overhaul was that you had to upgrade to 2015 CERT technology. Well, this is a whole new round where you have to be upgraded to 2015 Cures CERT technology. So for most people, this means an upgrade. So for Aprima, that 2015 Cures compliant version is going to be version 19. and that is set to be released in the coming weeks. So again, this means no one should be using a 90-day reporting period of January through March because this version isn't out yet, so that would be impossible. So you need to be on it in order to report your 90 days of PI data. Now, don't get confused, quality is a full year, and that started January 1st of this year. We recommend, I would say, for your PI reporting, until Q2 or later once you're on that version 19. So you can still run your reports and, of course, test your workflows, over what you learned today and try and master that process just to make sure you really have them down for when your reporting period does start. We absolutely encourage that. So how are we? Are we feeling okay? Are we overwhelmed? And if you are overwhelmed, that is completely okay. Obviously, we somewhat expected that, and I already mentioned this earlier, but this is our full-time job. This is our team's full-time job. And I'm sure for most of you on the line, it's not your full-time job. And the good news is, you don't have to do MIPS alone. It doesn't need to be your full-time job. Your DAS GI team is here to help. I'm sure you heard a theme throughout, right, of how we can help and assist you. But in all seriousness, we really do have all kinds of assistance packages to best suit your needs. Yes, we have an ongoing package that's going to be, what you see on your screen. It's going to be all-encompassing MIPS support from start to finish. We're going to look at your data analysis, report retrieval, quality measures training, workflow training for documentation. We're going to provide that performance analysis, and we're going to give you specific action items to improve your score. We're going to help you submit or just take it off your plate completely, and we're even going to give you audit guidance for your audit binder. Typically with ongoing support, we would meet on a regular basis. We like to do no less than quarterly, but I mean, our typical cadence with most clients is monthly. Even sometimes we meet with clients and it's the first, few months we're working together, we'll even go bi-weekly. And we're also, even willing to teach, your designated practice resource, the program, with the goal to eventually bring it in-house in the future. We completely understand. But that's ongoing. We also just have as needed packages. We have different packages, hourly packages. If you feel like you have a decent handle on the program, maybe you want a second set of eyes, maybe you just want to have someone to be able to go and ask those questions to, we are here. And then also for Aprima clients only, we offer completely custom monthly reports. And we'll take a look at these. So if you already work with us, these are going to look familiar, but here's an example of what these reports look like. We actually take your data from the reports we saw earlier today, all the yellow and all the words, and we run that out of your system, and we schedule it, and we set the parameters for you, and then we take the hard part out. We score your measures for you, including that quality benchmarking, and as well as the different PI measure weights to make it easy and understandable. So, the first portion, like I said, is going to be kind of that overall breakdown, giving you a nice summary here. A lot of our providers that we work with love this first page. And then, if we're working with any sort of clinical staff, office manager, et cetera, we can kind of dig into the nitty gritty on the additional pages. So you can see here, this includes the quality category with specifics with your actual score and how you're doing. And then also, obviously your PI category as well with everything that's required, and we track that for you. We also even put in workflow reminders at the bottom for how to meet each one of your quality and PI measures, so you know exactly how to improve your score. But that is it. We made it. So if you are asking yourself kind of what your next steps should be, we recommend you absolutely visit our website and you continue to sign up for our webinars. We are going to be hosting, as you saw with our upcoming webinar slides, throughout this whole year, definitely on a monthly basis, industry-wide webinars, but also Aprima-specific webinars. So also, if you have any ideas on certain topics you'd love for us to cover, I'm going to put up our information here in a second, so feel free to send those over to email us or even put them in the chat or that questions panel. But of course, if this did seem overwhelming or you just want another set of eyes looking at your data, or take this over for your practice, you're done with it, consider working with our team. You'd be working directly with myself, Kimmy, and Bridget. This is all three of us on the line you heard today. So if you are a current DAS client, reach out to your account manager. If you aren't a DAS client, you don't have one yet, you can email us directly. And here's that email address I mentioned. Again, Kimmy is absolutely our Aprima expert. We're all experts on the MIPS program and different systems and how to make it more manageable for your practice. If you are required to report under MIPS, I can promise you we will make your lives easier. And this program, overall more manageable for your practice. really anything we can do to assist you and anything we, action-wise that we take is going to have an ROI for your practice, either avoiding a penalty or earning an incentive, which is always our goal. And just to throw it out there, if you aren't sure if you were required to report last year in 2022, we can still look at your data until the beginning of March and create a plan or assist you for, at least keeping you safe from a penalty. If you already reported for last year and you're not worried about 2022 and you're focused on 2023, quality reporting, as you know, is a full year, so that clock is officially ticking. So I will go ahead and turn over to Bridget. She's going to get us started on questions that came in via the chat or questions panel while we were presenting. So Bridget?
Yes, I did get a couple questions. I know we are at time, so let me just quickly get these in. All right, so that one you kind of just answered. We talked about eligibility, and they would like to know if they don't know if they're required to report. What do they do, Lindsay?
Okay, yeah.
Can they look up their eligibility? Go ahead, I'm sorry.
Yeah, no, it's a great question. To figure out if you're eligible under the MIPS program, you want to go to qpp.cms.gov, and on that first homepage, there's what's called an NPI lookup tool. You can type in your provider's NPIs, and it'll tell you if you're eligible or not for each year. If you see a green check next to individual, that signals that you have to report, and if you're not reporting, then you're likely getting a penalty or a negative adjustment on all of your Medicare Part B claims.
Perfect. Kimmy, I have one for you, our Aprima expert. How do I know if I have a direct secure message license? And if I don't have one, what do I do?
Perfect question. So that'll live on the back end. So the best way to know for sure would be to contact your account manager, and they'll be able to verify in your configurations whether you have a DSM address. And then if not, we can get you set up with one, and just involves the licensing.
Perfect. Okay. Now I'm going to jump in and take a question because I cannot let Lindsay and Kimmy have all the fun. Are we required to report all 4 categories for a full year? I know Lindsay touched on this, but there was a lot of information reviewed today. So the only category you need to report for a full year is quality. Now, cost is for a full year, but you do not have to submit data on that. CMS will gather that information directly from your claims. So PEI, you're promoting interoperability and improvement activities need to only be 90 consecutive days, does not need to align with the quarter. Anything else, Lindsay, you think I should add to that, or is that pretty much good?
No, you got it. Yep, absolutely.
All right. Okay, and then one more thing I think Lindsay had already mentioned, we don't know if they're required to report in 2022, and is it too late? But we can still do the extreme and uncontrollable circumstances until March 3rd.
Yep.
Lindsay,
Perfect.
that's okay?
Yep, they are.
Yeah,
yep,
reach out to us if you need it. All right. And I know we're over time, so Lindsay, I'll let you close it out. Anything else?
Yeah, thank you so much, everyone. And I know I saw one last question come in of where can we get a copy of the slides from today and previous webinars. Great question. Just by registering and attending today, the recording link and the slides will be sent to your email directly that you use to register. But actually, as of right now, everything is being uploaded to our DAS Health YouTube channel as well. Like I said, if you're going through our previous or historical webinars too, feel free to shoot us a message on any ideas you have for us. We are definitely open and receptive to topics that you want covered, regarding Aprima or MIPS or anything of the sort. That is all we had for you today. We just want to thank you so much for attending, and feel free to reach out if you need help, but thank you so much.
Thank you.